Good morning, everyone. And this one is one more topic which I took from nephrology. And this one is UTI, urinary tract infections. Actually, I forgot like either we had done UTIs in infectious or not. I think we did not cover it because I'm sure, like, not sure, like maybe I have covered or not. But anyhow, today we are going to discuss UTI. So, urinary tract infections, just to tell you the importance of this thing. Um, One of the lecture, in uh, nephrology, I talk about urine dipstick, right? And I told you that it's a part of office test, which is done by the GPs or the general practitioners, in their office. Now, why? Because there are many reasons behind that. First of all, it's very common to get urinary tract infection, especially in females. Females get more of them than males, and the only reason is the length of urethra, because the males have uh, long urethra and the females have short urethra. So the bacteria found it easily to climb up the urethra and cause UTI. Okay. Secondly, um, the purpose of doing this urine dipstick is because um, the urinary UTIs, they present in number of, what you can say, um, clinical features are there. For example, in two old people, sometimes the presentation of UTI can be just like altered level of consciousness, or in too young, or it's not always like this that someone who have UTI they have like the same symptoms. There are some very non-specific type of symptoms as well. So um, now UTIs are the most common or most frequent bacterial infection in females, and most of the time it comes when they are sexually active, and it's very 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 common to reoccur as well in females. So there are many important points which we are going to cover in this one. So these are some of the things which are, you can say, some points which you can go through, which will help you. Uh, for example, strangry. It is difficult and painful micturition with associated spasm, and whenever there's inflammation of urinary tract, so that leads to passage of small amounts of urine and sense of urgency. Urethritis usually causes pain at the onset of micturition, whereas cystitis usually causes pain at the end of micturition. Very, very, very important point clinically, right? Because when you're taking history, you can differentiate. Suprapubic discomfort is a feature of bladder infection. Cystitis is the bladder infection, and vesicoclonic fistulas like prostatic cancers can cause severe dysuria, pneumochuria, and foul smelling urine. Okay, very less common, but of course, like this is one of the helping point. And dysuria and frequency are most common in women age 15 to 44. Basically, you can say the child producing age or the sexually active age. And they are four times more common in sexually active women. Vaginitis is an important cause and must be considered. Dysuria and discomfort is a common feature of postmenopausal syndrome due to atrophic urethritis. The urethra and lower bladder are estrogen dependent. Okay, this is something maybe like it's hard for you to understand by now, but of course, like when you will be studying gynecology, also like you would be understanding this thing why they have mentioned this thing. because postmenopausal women, like, uh, you can say their mucosa goes, you can say, atrophic, right, because of less estrogens. So that's why they have this thing. And UTI or other disorders can be quite asymptomatic. This is the point I was talking in the start. And again, key effects and checkpoints. Screening of asymptomatic women has shown that about 5% have bacterial UTI. So see, like, how common it is. About 1% of neonates and 1 to 2% of schoolgirls have asymptomatic bacteriuria. What is that? I will tell you, like, this term. About one third of women have been estimated to have symptoms suggestive of cystitis at some stage of their life. The vast majority of these women have anatomically normal renal tract and at no significant risk for the UTI and respond quickly to simple therapy. UTI is largely caused by organisms that from the bowel that colonize the perineum and reach the bladder by urethra. Okay, now it's a very important point, like, and this will help you to remember the most common cause for UTI, which is E. coli. And in young women, of course, infections are precipitated by sexual intercourse. One thing is called as honeymoon cystitis as well. We'll discuss that. Hematogenous infection can occur sometimes, especially with the immunocompromised patient, and all females and males less than 5 years presenting with a UTI require investigation for an underlying abnormality of the urinary tract. So again, a very important clinical point. In the presence of a normal urinary tract, there is no evidence that UTI leads to progressive renal damage. So, okay, these are again like maybe too many, but if they stay in the mind, so that's a very good thing. These are few things, one term is called as sterile pyuria. So simply, what is pyuria? Like, this is pus in the urine. So whenever there is pus in the urine, but when you will send the urine for culture and you did not found any organism, so what can be the causes of that? Contamination of poorly collected urinary specimen, urinary infection being treated by antibiotics, and many other things. Then there is asymptomatic bacteriuria, and this is defined by the presence of significant growth of bacteria in the urine, but there is no symptoms. And again, like on close questioning, many patients admit to mild urinary symptoms. It is common in sexually active females. Then there is symptomatic bacteriuria. So, what is symptomatic bacteriuria? It is simply the presence of the symptoms of UTI, which is frequency, dysuria, and loin pain. And when we send the urine sample to the labs, we can found the organism. So that is called a symptomatic bacteriuria. Now, acute cystitis. What is acute cystitis? Cystitis means inflammation of the bladder, right? So inflammation of the bladder, whenever it is there, of course, like the patients, they present with pain during micturition, which is called as dysuria, and urinary frequency. They have to go to the toilet, like to empty their bladder again and again. Constitutional symptoms are minimal or absent, and other causes of dysuria and frequency include urethritis, prostatitis, vulvovaginitis, things like this. Uh, then there is acute pyelonephritis. Now, what is pyelonephritis? Simply, it is inflammation or infection of the kidney, right? So, whenever there is pyelonephritis, remember, guys, it presents in a different way. Fever, loin pain, rigors, nausea, sometimes vomiting. And whenever acute pyelonephritis is there, like in surgery, you will study acute abdomen cases in which all the causes, all the cases, all the things which can cause abdominal pain, acute pyelonephritis is one of them. Okay, now what is uncomplicated urinary tract infection? So, okay, you can say it's a classification as well. We classify UTI as uncomplicated or complicated, right? So, uncomplicated UTI is simply a UTI with structurally and functionally normal urinary tract. Okay. And complicated UTI is anything with structural or functional abnormality, or whenever the UTI occurs in males, immunocompromised, or diabetic people, especially and also in pregnancy. We call it as complicated UTI, right? So remember the difference between uncomplicated and complicated. Now, I will tell you the definition of UTI, guys. I haven't talked about the definition yet, right? I'm just uh, making you familiar with different things which will come along, right? Especially when we'll discuss the treatment part. Then there's something called as urethral syndrome. So urethral syndrome is basically a diagnosis of exclusion in patients with dysuria in frequency and documented infection. What I mean to say by documented, like when you will do the labs, you will found the source of the infection. So see, the urethral syndrome, sometimes termed as abacterial cystitis, is that where the patient presents with dysuria in frequency. Okay, uh, sorry, without. I'm sorry, without demonstrated or documented uh, infection, right? So we call urethral syndrome when, or it is also termed as abacterial cystitis. So remember, abacterial, like of course we cannot find bacteria. So the person have the symptoms of UTI, but when we test their urine, we cannot find anything. We call it as urethral syndrome or abacterial cystitis. And you can see, like, 30 to 40% of adult women, or many actually have bacterial cystitis but a negative culture. And the organisms may be anaerobic or fastidious in their culture requirement. And the organism may include, like, these one or viruses, or the urine maybe have antiseptic contamination, things like this. Of course, antiseptic contamination is going to kill the organism and will give the negative urine culture result, right? So that's make an important point here. Like in UTIs, what we do, like we collect the sample of urine, and the collection of sample of urine is very, very, you can say, important thing, because while collecting sample, we can contaminate the sample simply. Okay, epidemiology, I already talk about this one, right? More common in females and all those things, right? And I will talk about the definition now. We have discussed all these things, right? And this is the definition of cystitis, and this is the definition of pyelonephritis. But I will give you like other type of definition as well. For example, okay, I will tell you, we divide UTIs into lower and the upper UTI. Same like respiratory tract infections, we say like lower or upper, right? In this one, we do same. We say lower or upper. So the important thing to remember over here is lower UTI is simply when the infection is in the bladder with the prostate, and upper UTI is simply when the infection is in the kidney or pyelonephritis. So this one is an example of upper UTI, not lower UTI, right? Okay, so this is the definition of prostatitis, like inflammation or infection of the prostate gland and all these things. But okay, now see, like these are because see, uh, maybe you're confused with the definitions, but see, bacteriuria or asymptomatic bacteriuria or cystitis, pyelonephritis, prostatitis, as well as like all these things. Of course, they are what you can say the definition of UTI, right? Now, to add something here, a type of definition which I want to talk about is simply we say someone have UTI when the symptoms are suggestive of UTI plus evidence of pyuria and bacteriuria on urine analysis, right? Or you can say urine culture and sensitivity. Okay, so like the person is giving, uh, sorry, the person is coming with the symptoms which are suggestive of UTI, plus we have the evidence of pyuria or bacteriuria or on urine analysis and culture and sensitivity. We say that the person have what? The person have UTI, right? So this is of course like the symptoms are there. Remember the thing, the symptoms are there. If asymptomatic, if the person don't have symptoms, like if the person is asymptomatic, plus when we do analysis, we found 100,000 of you can say clonine forming units CFU per ml of the blood. Okay, uh, we call it as asymptomatic bacteriuria. Okay, okay, this thing we had discussed here as well. For example, this one here, or I show you the same thing over here as well, right? So asymptomatic bacteria, of course, like we found bacteria in the urine, but there is no symptoms. Okay, so uh, now the definition, the exact definition is simply uh, when you found that the patient is asymptomatic and they have like 100,000 of colony forming units, while when you send it for culture and sensitivity, right, you will label them as asymptomatic bacteriuria. What is the importance of this thing, guys, is simply that most of the time it doesn't require any treatment. Just only time when we treat these patients, people, is only in pregnancy. Okay, so what is the importance of this thing? These people, they require treatment only in pregnancy or only in certain cases, right? So that's the importance of this thing. So, sorry. Okay, so I told you what is complicated infection, what is uncomplicated one, right? Now there could be relapse. Relapse means what? Recurrence of the infection with the same organism after discontinuation of the treatment, and there could be reinfection when someone have a UTI and you treat that, and then they have one more UTI but with a different organism, right? So uh, that's a point here. So I hope you understand these things. So now E. coli, uh, which is the most common cause of UTI, uh, they have flagella, uh, so they like for their motility. So what other thing it do, that they have something called as adhesins. So due to that, they can attach and they can climb, they can move. Okay, and There are like two type of E. coli, by the way, but I don't want to go into much detail of that. There is type 1 with, you can say, type 1 which have adhesins, okay, and there is other type which also have adhesins but like of different type. So of course, like I'm not going in all that detail for now, but there are many factors, which play a role, like when the patients have infections, uh, like how is the immune response of the body is, okay, how the body is responding, and what are the organisms which is what you can say uh, attacking the person. Of course, like the most common is E. coli, but there are others as well. As well as like how much is the urine flow. For example, if someone has stasis, like due to stricture, someone has stasis. So of course, like we have stasis UTI, or like due to stasis, of course, like that increase the chances of getting UTI, right? So there are many factors which do play role in this one, right? So so when we are talking about this, of course, we have to discuss the risk factors also. So what are the risk factors in females? Pregnancy, estrogen deficiency, diabetes in males, lack of circumcision. Okay, the evidence is not so clear. Prostatic hypertrophy in both like old age urinary tract obstruction, in which like there is stricture, vesico-ureteric reflex or instrumentation, or iatrogenic, neurogenic bladder and renal transplantation, right? Uh, by the way, you can also classify them as uh, one more way, uh, risk of risk factors, you can say, for UTI. Another way of classification, number one, it can be stasis and obstruction. Uh, Number second can be foreign body. Okay. Number third can be decreased resistance to the organism. And number fourth is other factors. Okay. So when I will talk about the stasis and obstruction, see what other things can come inside this one is stricture, for example, benign prostatic hyperplasia in males, a neurogenic bladder. When I talk about the foreign body, remember, like, catheterization is very, very, very common in the hospitals, as well as instrumentations. We do instrumentation the urinary tract, of course, for diagnostic or therapeutic purposes. So that thing can cause decreased resistance to the organism. I think it's very easy. Um, Immunosuppressive drugs, diabetes, old age, malignancy, less estrogen. So that's why, after menopause, they can have this. And other factors like trauma, anatomical abnormalities, females is also a risk factor, sexual activity, menopause, fecal incontinence, all these things can be considered as risk factor for UTI. So see this one, like I was talking about the host defenses, bacteria assessing the blood are eliminated by flushing mechanism, urine inhibitors like the pH osmolality, urea. There are uroepithelial deficiencies, and there are TOM, uh, horsefall, proteins are also there, right? So, what is this TOM, horsefall proteins? Like they are present in the mucus of the urothelium, and they have antibacterial properties. So simply these proteins interfere with the bacteria and protect us against the infections. Okay. So whenever we can cause trauma to the mucosa by sexual activity or catheterization, like that one, predisposes to UTI. And uh, one very interesting thing, that like it is said, like whenever someone have UTI, so they must drink cranberry juice or blueberry juice, right? What's the reason behind that? Because cranberry juice and blueberry juice, they contain large molecular weight factors. Uh, they are called as proanthocyanidins. So they prevent the binding of E. coli to the urothelium. So there are many factors, which play a role in this one. So now, guys, what you can say, I will talk about the. Okay, this is all pathogenesis, guys. Of course, we are discussing it from. Okay, it's causative organism first of all. Very, very, very important thing. When it comes to the causative organism, you can remember typical organisms, right? Like the bacteria, like the infection is caused by typical as well as atypical organisms, right? So I remember it like this way. I'm going to remove it all and I'm going to mention it in my way. You can say there is typical organisms um, as well as there is atypical organisms. Now, when it comes to the typicals, not a good mnemonic because again, the most important one comes later. Keeps. Remember keeps, and what is keeps is simply K is for um, Klebsiella, E is for E. coli. Sorry, E. coli. Okay, I don't like this mnemonic. I always say because in this one, E. coli is the most common one, up to 90% of the time, and some of the books say up to 95% of the time. The infection is by E. coli. Of course, like these are all the studies which they have conducted just to see what is the organism which is causing. So E. coli can cause, right? Klebsiella. I'm not sure about the spelling, like if the spelling is correct or not, but I think it is right because it gives me Klebsieliosis, right? And the other E is Enterococci, and P is Proteus, as well as Pseudomonas. Okay, uh, PSU, Pseudomonas, and S is for Saprophyticus. Saprophyticus. Okay, so these are the typical organisms, and the most common one is E. coli, right? The most common one is E. coli, and of course there could be atypical organisms as well. For example, when it comes to the atypical organisms, it could be TB, it could be claim, uh, chlamydia, it could be mycoplasma, it could be fungal infections like Candida. Now, see, the atypical organisms causes atypical infections, right? So this is how it goes. E. coli here they're showing you like less because in many of the books it is written like 75 to 95% cases are due to E. coli, and what they are showing you is like 75%, right? So it's like this. So now majority of the UTI is due to single pathogen. Now the clinical features, of course, like there are asymptomatic cases and there are symptomatic cases. So asymptomatic cases we had already discussed, right? And then there is symptomatic cases, of course, in which if there is cystitis, there can be frequency, dysuria, urgency, suprapubic discomfort, tenderness, fever is often absent. Whenever it is acute pyelonephritis, remember there is fever with chill and rigors, there is flank pain, there could be frequency, there could be, and in the elderly, as I told you, the symptoms are atypical, right? So, okay. So now, before going on further, I will tell you a very important thing. Again, like I'm talking about clinical features still. I'm not moving further. In clinical features, one of the things which you must know about is uh, this thing is going to help you in surgery, especially when you are going to study benign prostatic hyperplasia. Whenever like the urinary tract is involved, there can be storage symptoms, and there could be voiding symptoms. And what are their like storage symptoms? Like of course their bladder is there to store the urine, right? So whenever there is UTI, the storage symptoms are basically frequency. Someone who have to go to urinate again and again. There could be urgency, like at the sense of having urination, like you have to rush to the toilets. Okay, and there could be dysuria. Dysuria is of course like painful micturition. And whenever it comes to the voiding symptoms, like when you're voiding, when you're passing the urine, what can be the symptoms that are there? Hesitancy, um, dribbling, basically post-void dribbling. When you finish the urine, like there will be drops which will still come on, as well as dysuria uh, while while voiding. Okay, they can be there, and of course suprapubic pubic pain can be there. This is one of the feature. Hematuria can be there, blood in the urine, right? Foul smelling urine in case of there is fistula, or the fistula is coming. Yeah, in what cases fistula can be formed? For example, someone have a colon cancer, right? So when someone have colon cancer, what happens is like uh, there is abnormal communication formed between the bladder and the colon, and what happens like the colonic material it started coming in the urine, so there could be foul smelling urine. By the way, it's not the only reason, because whenever someone have UTI, they do have foul smelling urine, right? But that is one of the things. And as I told you, whenever it is pyelonephritis, the patient present with more severe symptoms of fever with chills, and flank tenderness, okay, as well. So this thing is important, right? So now, okay, leave this thing for a while, because again, like they are talking about predisposing factors which can lead to UTIs, right? Uh, which we have already discussed. Okay, catheter associated UTI, or you can say hospital acquired UTI. Uh, of course, we have to think about other organisms as well. Okay, and in this one, antibiotic resistance is quite common feature which you can found in these patients, right? So now, um, the important thing over here is investigations. Okay, maybe you will get scared while looking investigations, but they are not so much investigations. Rather, one or two is needed generally. But of course, like we are talking about a lot of things, and what to do and what not to do, and of course, like this is a common problem. So trouble, complaints. So that's why I'm talking about the details here. Okay. Uh, when we go for test, or what are the indications for doing test? There are many indications. For example, if someone have pyelonephritis, it needs investigations, right? Someone who have symptoms even after antibiotic therapy needs investigations. Someone who, in which, for example, creatinine is increasing, needs investigation. Someone who have atypical organism, they need more investigations. Um, Talking about what you can say, uh, the investigations, you can see investigation indicated in all children, all male, and all women with. So you are going to do investigations in all children, all males, all women with, not all women, only all women with acute pyelonephritis, recurrent infection, confirmed sterile pyuria, and other features of renal disease, right? I will make it bold, like just to divide the things in. Basic investigations which we do for all the patients is midstream urine microscopy and culture. Okay, just to see what is the organism. We can do renal function test. We can do intravenous urogram, or ultrasonography can be done. And special considerations are done in children, like whenever the children have UTI. So just to rule out, like either they have some anatomical abnormality of the urinary tract, we can go for cystogram, micturating cystogram. One of the things is called as reflux nephropathy, in which when the child they urinate, what happens? The urine go back and hit the kidney. You can say can lead to hydronephrosis as well, and can lead to renal scarring as well, and can lead to renal failure as well. So, whenever the children get UTI, we always rule out that thing. Micturating cystogram is for that. And in adult males, considered prostatic infection. In severe pyelonephritis, do ultrasound sonography or intravenous urography urgently. And in pregnant women, always do ultrasound to exclude obstruction. Okay, what is urine dipstick? I had a lecture on that. And it's office test. And you can say once like we get positive urine dipstick, then we go for urine examination. So we send the urine for microscopy, and we can send the patient for send the urine for culture, okay, as well. Now to do urine urine microscopy and culture, what is the thing we must do is we have to give them MSU. What is MSU? It is midstream specimen, okay, or midstream urine. MSU, midstream urine. So how we can cleanly catch the urine or midstream urine? To the adults, we simply say that, okay, we need your urine sample. What you have to do, when you will start micturating or voiding or urinating, let the first part of the urine, for the first half of the urine, the first 1/3 of the urine, you can say, to go waste it, don't collect them. Collect the middle stream, the middle 1/3 urine, and don't collect the last 1/3 of urine. So what we want to collect, like just the middle part of the urine. That's why it's called a midstream urine. Now children, they cannot do this thing, right? So in children, we have collection bags. If that is not possible, we can go do suprapubic aspiration, or we can collect by catheters. Okay, and this is like how is the specimen transport, guys. Basically, you don't need that. Okay, so of course, like, so the investigation. See, we can do urine dipstick, we can do culture, we can do blood test. Okay, what blood test we can do? I'm going to add them over here. Sorry, here. We can do blood, CBC, okay, as well as we can do urea and electrolytes. And we can do CRP and ESR, right? Sometimes you can also go for blood cultures, but not usually done. So okay, so these are first of the like few of the points about the treatment or the treatment of uncomplicated urine. So I told you what is complicated, I told you what is uncomplicated, right? Uncomplicated when there is no associated disease, and complicated when there is abnormal urinary tract with any other disease like diabetes, sickle cell disease, analgesic nephropathy, stones, obstructions, XYZ, right? Why? Because in complicated one, there can be the risk of kidney damage. So now, how we treat these patients, how to manage UTIs, right? So again, few of the things you can see. Recurrence occur in some patients usually within 2 to 3 months, and frequent recurrence usually occur in clusters. Recurrent uncomplicated UTI does not lead to chronic renal failure, and recurrent complicated UTI may lead to renal failure. UTI may accelerate progression of underlying renal disease, right? So, how we treat them, guys, One thing is called as, okay, acute pyelonephritis. Uh, Mild infection treated orally with fluoroquinolones or cotrimazole or third generation cephalosporins. Then there is moderate to severe infections. So this thing, how we treat cystitis, too much medications are written for how many days, how to treat asymptomatic bacteriuria, of course, just treat them in pregnancy, and what to do when there is a relapse or recurrent UTI. So there are few guidelines. For example, don't use antibiotics for uncomplicated UTI, or sorry, don't use antibiotics for asymptomatic uncomplicated bacteremia, right? So, or you can say simply asymptomatic bacteriuria. So we don't treat them. Only way we treat them is when the patient is pregnant. Okay. So there are guidelines. For example, uh, one of the guidelines is simply anyone who have uh, treatment. Anyone if there are 3 or more symptoms, okay, of cystitis, so we treat them with trimethoprim or nitrofurantoin, okay. And whenever, of course, like in pregnant women, we always treat like asymptomatic bacteriuria as well, okay. So uh, the point is what drugs can be used, right, for the treatment of uh, what you can say urinary tract UTI. So of course we give them antibiotics. Now I'm winding it up, right? And the antibiotic should be given for 3 to 5 days. Like for example, amoxicillin can be given, or one of the drugs which is very important and common is nitrofurantoin, okay. Or one of the drugs which I already mentioned before is like trimethoprim, okay. Fluoroquinolones can also be given, right? Fluoroquinolones. Cephalosporins can also be used. Cephalosporins can also be used. Okay. So now, if someone have recurrent infection or resistance of treatment, then choose fluoroquinolones. Otherwise, don't eat. Then go for fluoroquinolones. Okay. So we encourage them to drink more water, around 2 liters per day. We give them anti-inflammatory drugs if there is pyelonephritis or if there is any painful maturation is going on. We ask them to drink cranberry or blueberry juice. Okay. So these things. Now, one of the thing, guys. Okay. So no treatment women with dysuria and frequency mainly because they are less than 10 colony forming unit in MSU. Over treating women with acute cystitis or normal urinary tract. Single dose therapy is effective in 70 to 80% of cases. And using single dose uh, therapy in patients with known anatomical abnormalities. Of course, don't make this error. Okay. And failing to consider chronic prostatic infection in women with recurrent UTI or normal intravenous urogram, right? So these are the treatment errors which we can commit while treating the patients with UTIs, right? So the treatment basically we give for like 3 days to 5 days, but it meant like we consider like prolonged treatment. For example, if you are giving trimethoprim or nitrofurantoin, whatever is your choice, give it for 7 days. And if the man have prostatitis, then 4 weeks of treatment can be given. Okay. One of the things which we ask the patient to do is simply uh, we tell them how to uh, avoid or prevent UTIs, right? So few points, to tell the especially your patients, prevention of UTI is maintain good hydration around 2 liters per day. Okay, uh, cranberry or blueberry juices are good to prevent. We always say the females wipe from front to back because if when they wipe from back to front, of course they can bring the bacteria towards the uh, urethra. So of course, like that area can be contaminated with feces from rectum, so can cause this thing. Also, we ask the females especially to avoid, um, you can say, products or cosmetic products, around that area, or there are some hygiene. So avoid hygiene sprays, avoid scented douches, and one very good way is to empty the bladder uh, before and after the intercourse. Okay, very 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 important. So these are the things we tell the patients to do uh, in order to prevent UTIs, right? So I gave you the list of antibiotics, guys, right? And this is how we treat them. So depending on, of course, like what the patient have, you're going to choose the antibiotic regarding like keeping in mind like the cause of a UTI and stuff like this, right? So simply uh, like any antibiotics are used, but I told you the one which, for example, like nitrofurantoin is used a lot, as well as you can say that one, amoxicillin, okay, or trimethoprim is used a lot to treat UTIs. Rest, of course, like you can give other antibiotics as well, but the basic point is to cover, um, especially to cover E. coli, right? E. coli is very 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 important organism for this thing. And whenever it is pyelonephritis, guys, the treatment is a little different because in pyelonephritis, uh, okay, whenever it is pyelonephritis, then of course, like uh, we start with IV antibiotics, right? Because sometimes they are like in a very bad shape, so admit them, treat them with IV antibiotics, right? And what you can say, always look for any complications like maybe they have developed abscess, so do investigations like CT scan can be done for that, or ultrasonography can be done for any complications like formation of abscess in that patient. So that thing. So you had done STIs, by the way. Urethritis is when we were discussing in infectious disease urethritis. If you remember, there was gonococcal urethritis as well as non-gonococcal urethritis. So if you're suspecting gonococcal urethritis, of course, use ceftriaxone. If it is non-gonococcal urethritis, use azithromycin. Uncomplicated UTIs, try methoprim sulfamethoxazole or nitrofurantoin, right? And whenever it is complicated one, choose ciprofloxacin or ceftriaxone. And whenever it is recurrent infections, give the antibiotics for 3 weeks. Okay, sometimes we give the antibiotics for even months. Okay, so we can choose the antibiotics like this. So thank you so much, guys, for listening.